Welcome to Ask Sid, the official podcast for Sydenham Clinic, a clinic where luxury meets medicine. We are on a quest for longevity. And I am so thrilled to be your host on this show. My name is Anchal Bhatia. I am the founder and CEO of Sydenham Clinic and the author of Your Doctor Is Not God and How to Be the CEO of Your Health. I look forward to taking this journey with all of you and having amazing thought leaders, guests, and members of our Sydenham team answering questions that you put forward. And I urge you, and I hope you will, ask Sid more questions on longevity, wellness, living to your highest potential. We are all trying to be the best versions of ourselves. And our physical, emotional, and mental health is foundational for us to achieve health and success in other realms of our life. So welcome to Ask Sid.
Hi, I'm Dr. Terry Rice, and I'm here today to continue our Ask Sid podcast series. And I am here at Sydenham Clinic, and today I'm going to be doing a solo presentation, and we're going to be talking about menopause and hormone replacement therapy. So why do I want to talk about this? Well, this is one of my favorite topics, and it's certainly a topic that seems to be very important to many of the new patients that I see, and a lot of the women that I talk to are very interested in hormone replacement therapy. And I think that this is an area that women have suffered a disservice from in the last 20 years after this important study called the Women's Health Initiative. So this is a study that was done in 2002, or was started then, and the upshot of the study was to scare women out of hormone replacement therapy due to fears of increasing the risk of breast cancer. Now, many years later, it turns out that that was maybe a slight misinterpretation or overinterpretation of the findings. So if that's something they're really interested in, digging into the details of the Women's Health Initiative and the impact it's had on women's medical care, I would recommend reading the book Estrogen Matters by Dr. Avram Bluming and his co-author. I think it's just a great treatise on this because it's a lot more detail and things like statistics that I'm going to be able to go into today. But anyway, that's why HRT is a hot topic, because it's like a new topic, because for about 20 years we kind of like took a pause in giving HRT to women. That's hormone replacement therapy. So let's talk a little bit about menopause. So menopause occurs on average between the ages of 50 and 52, although it can, range between 45 and 58. And during that time period, for 2 to 8 years before menopause actually occurs, women start to also experience changes called perimenopause. And in this time period of perimenopause, there can be a lot of different changes that occur, because menopause in each woman is as individual as your fingerprint. So we all go through this in a different way. So in perimenopause, what we often see is some wild fluctuations in estrogen levels, and then maybe some drops in progesterone levels or drops in testosterone levels. But that's not the case with everybody. But as you go into menopause, again, it can be different in different women. And that's why it's important to really get a good blueprint and do the testing to understand which hormones that you're missing, which hormones that you need, and what are causing your symptoms. So like I said, it can be different in everyone. And one of the most common things that we see is women lose their testosterone. So testosterone starts to fall off in your 40s. And then a lot of times by the time you go through menopause, when your ovaries really stop working and you stop having a menstrual cycle, in many women, testosterone reaches an unmeasurable level. Who cares? Why is this important? Well, something that many people are not aware of is that testosterone in women is just as important as estrogen, and it's almost as important as it is in men. So depending on how you measure testosterone, premenopausal women may have more active testosterone on board than they have estrogen. So testosterone is a really important factor, and loss of testosterone has a lot of symptoms. So probably the one that receives the most press is lack of libido. So a lot of things are important for libido or our sex drive, but in women, usually testosterone is the major driver. Now, along with testosterone, you need adequate levels of estrogen as well, but libido is very important for sex drive, and it also has a lot to do with how sex feels, how satisfying it is, and a lot of psychological aspects as well. So in some women, their testosterone just goes away. In other women, they maintain testosterone until they're 75 or 80 years old or for the rest of their life. So it's important to know. Another aspect about testosterone that I think is a really important caveat is currently there is no FDA-approved supplement for testosterone for women. So it is FDA approved for men, but the only way for women to really access testosterone is off-label. This is a big hurdle for women in getting care after menopause. The other common pattern that we see in menopause is low progesterone. So this may not present with hot flashes, but when your progesterone gets low, you don't sleep as well. So in many women, they may have what seems to be normal estrogen levels, and they may still be cycling, but their progesterone may be low. And this is what we call estrogen dominance. And this can result in symptoms like irritability, mood swings, and also really problems, difficulty sleeping at night. Why is progesterone so important to help us sleep at night? Well, progesterone increases the production of GABA, which is a very calming neurotransmitter. And GABA tends to go up at night so we can relax and go to sleep. So without the progesterone, we may have more anxiety. We may find ourselves lying awake at night worrying or just not really understanding why we can't sleep anymore. Then the third hormone, of course, to fall with menopause is, of course, estrogen. And this is the one we hear about all the time. Everybody thinks hormone replacement therapy is just about estrogen and that menopause is about lack of estrogen. But it's really much more complicated than that. But the symptoms that we think of a lot with menopause have to do with low estrogen, and those are what we call the vasomotor symptoms, such as hot flashes, difficulty sleeping, palpitations, maybe mood swings. So these are some of the things that we hear about a lot and that are the symptoms that are usually aimed at treating with hormone replacement therapy. So I'd like to talk a little bit about how I approach menopause with women, how we treat it, and why. And so there's several different options out there. The old-fashioned way that we used to treat this was with oral estrogens and something called progestin. This was the typical Premarin and Provera that was given 30 and 40 years ago, maybe more. This was a synthetic estrogen that was actually made from the urine of mares, pregnant mares, and then the progestin was a synthetic progesterone. Now, most women are leaning towards using more natural products, which we call bioidentical hormones. So currently, I think that the first step in treating hormone replacement therapy or menopause, unless you're just replacing a specific hormone that's missing, like just the testosterone is missing or just the progesterone is missing. So if you're going to really see someone who's pretty much gone through menopause and doesn't have any hormones left, then of course the cornerstone of therapy is estradiol. And estradiol can be given multiple ways, but my go-to is through the skin. So this is called transdermal estradiol. It's usually given in a patch that's changed twice a week. That's the most standard therapy. Why? Why are we not giving it by mouth? Why are we giving it through the skin? Well, when estrogen is given by mouth, it goes through the GI tract, and then about 80% of it is metabolized in the liver. So you have to give 100 milligrams to get 25 milligrams into the system. So the problem with that is that it stimulates the liver to produce other proteins, and some of those proteins increase your clotting factors. So this is why in the past, people have been concerned that estrogen therapy increases the rate of stroke and blood clots, as in found with the birth control pill, which is an oral estrogen. But if you give it through the skin, then you don't have that effect on the liver and you don't have the increased risk of blood clotting. So I like to start women on a low dose of estrogen through a transdermal approach. And then along with that, I like to give them progesterone as well. So the dose of progesterone can be adjusted on an individual basis. We usually give it orally because you can't give adequate progesterone at night. You can't give adequate progesterone. We usually give it orally because you can't give adequate progesterone through the skin. Okay? So we usually give it at night because that's when it helps with sleep. Now, why do we give progesterone? Like a lack of progesterone doesn't always cause these vasomotor symptoms. But if you do not give progesterone to a woman who has an intact uterus, then the lining of the uterus can get thicker and thicker and can deteriorate into malignancy. So if you haven't had a hysterectomy, you have an intact uterus, and you take estrogen, you do need to take progesterone as well. So those are the cornerstones of therapy. That's how we usually start. We usually start at a low dose so we don't have as many problems with breakthrough bleeding. Most women don't want to go back to a menstrual cycle, nor do they want to be bothered with intermittent bleeding that's unpredictable. They don't know when it's going to start. They don't know when it's going to stop. That's no fun, right? So if you start low and gradually increase the doses, then symptoms like cramping, breast tenderness, and breakthrough bleeding are usually minimized. However, there is no special formula to prevent breakthrough bleeding. And as long as you know that the lining of your uterus is not thickened, which you can tell with an ultrasound, then usually you can work through the bleeding, which is very common in most women when they start treatment, and it gradually just goes away as your body gets used to the therapy. And then I think one of the most important things also is replacement of testosterone in women who've had a loss of their testosterone with aging. And I like to do this through a topical cream. And this is something that you can just rub into your skin. Once a day is usually enough. And in that cream, you can put in other hormonal precursors or hormones that tend to go down with aging, such as pregnenolone, which is a hormonal precursor. It can be a pro-hormone for multiple different hormones, and DHEA, which is a precursor to testosterone. So I find that topical cream that contains testosterone gives many women back the libido that they had when they were younger. Now, it doesn't work for everyone because the absorption of cream is very variable from one person to the next. So if the cream doesn't work for some women, you can gradually increase the dose. And then other options are to give it in an injection form or in pellets. So what are some of the side effects of these therapies? Well, some women get breast tenderness, some get some cramping, some get breakthrough bleeding. And then with testosterone, the rate-limiting side effect is usually acne or hair growth. So after a few weeks, if the testosterone dose is a little high for you or you're sensitive to it, you might start to get some acne. And after a few months, some women start to notice that they get some increased fuzzy hair, in the mustache area or under the chin or just all over their body. They may get a little bit more hair. So usually at that point, you can just cut the dose back if the person finds it to be bothersome. So those are the kind of the cornerstone of how I like to do this treatment, and the idea is to just start low with low dose, go slow and gradually increase as people adjust to the medication. It's important, if possible, to start hormone replacement therapy as close to the cessation of menstruation as possible, because the benefits, including improved vascular health, improved bone health, improved brain health, all seem to be related to starting the HRT pretty close to the onset of menopause. It's questionable as to if you wait 10 years or more after menopause and start these therapies, whether there is a definite benefit or not, although there may be a quality of life benefit at many ages. So I think some of the other things that are important is trying to monitor the levels of hormones and to monitor how they're metabolized to try to make sure that this is done as safely as possible. So all of my patients that are getting hormone replacement therapy are getting an annual mammogram and breast exam. They're all getting a pelvic ultrasound as well, just to look at the lining of the uterus. I feel like that this is a no-brainer screening test because there's no downside, there's no radiation involved, there's no dye, but it's a good way to take a look at the ovaries and make sure there's nothing concerning going on there, and to make sure that the HRT is balanced in a way that the lining of the uterus isn't thickening. Other tests that I think are really beneficial, one is a test called the Dutch test by Precision Analytics. And I like to use this in women after we get them on a dose that we feel like is good for them. So when we think they're stable, then we like to get this Dutch test. And the Dutch test looks at urine specimens and saliva specimens. But for the steroid hormones, our sex hormones, the main thing is looking at the urine specimen. And what it does is it looks at your function of your adrenal glands, so how much DHEA and testosterone you're making from your adrenal glands, because that can be the main source of testosterone after menopause. And then it looks at your 3 different estrogens and how they're metabolized. So estrogen's pretty complicated. We have 3 different estrogens: estradiol, which we think of as our sexy estrogen; estriol, which is kind of an anti-estrogen, protective estrogen, tends to be very high in pregnancy; and then estrone, which tends to go up as we get older. And if you have more adipose tissue on your body, your estrone levels can be elevated as well, because your estradiol is metabolized in your adipose tissue to estrone. So estrone is broken down and goes out of your body in 3 different pathways. One is called the 2-hydroxy pathway, is a very safe way for your estrogen to be metabolized. And that's what we want to be emphasized in our patients, is that their estrogen is leaving their bodies safely down this 2-hydroxy pathway. So I won't go into all the chemistry of that, but it's very technical. But there is also a pathway called the 4-hydroxy pathway. And this forms what's called a quinone. So when your estrogen is metabolized down the 4-hydroxy pathway, you have increased risk of breast and uterine cancer. Then the 3rd pathway is called the 16-hydroxy pathway. And in that pathway, the estrogen doesn't tend to leave our body like it should. It tends to stay around longer, kind of be metabolized in a circular way, and can increase the risk of things like fibroids, possibly endometrial hyperplasia. So let's go back and talk about, we have these 3 pathways. The 2-hydroxy, we want about 80% of your estrogen going down that. The 4-hydroxy is the bad pathway. We want like 10%, a little less, going down that, and about 15% down the 16-hydroxy pathway. So if we look at these pathways, we can manipulate them both with diet, lifestyle, and supplements. So particularly if I have a patient that we know tends to metabolize our estrogen down a dangerous pathway, then we want to minimize that, and we don't want to push those estrogen levels very high. So for example, things that increase that 4-hydroxy pathway, the more dangerous one, are alcohol and weight gain, and then stress, and then some of this is just hereditary. So if you have a tendency to metabolize your estrogen not in the safest way, then we want to talk to you about getting to an ideal body weight, reducing alcohol consumption, reducing stress and oxidative stress and inflammation, and then perhaps adding supplements, things like vitamins that help with methylation, resveratrol, DIM, things that help encourage our estrogen to go down that pathway. So these are some of the tests that I use to kind of measure my patients and try to perform hormone replacement therapy as safely as possible. Some of the other things that we do is we look at salivary hormone levels, because when you give hormones through the skin, particularly in a cream that's been compounded, then it's difficult to measure accurate levels in blood, because these hormones are lipophilic, meaning they're fat soluble, so they don't tend to go to the bloodstream as through the fatty, the adipose tissues. So that's just kind of in a nutshell about the way that I like to do this. There are certainly other options. In some patients who don't seem to respond well to testosterone or to this treatment, we do pellets. So this is where you take a solid form of estrogen and testosterone and put it under the skin, usually in the hip area, and that needs to be replaced every 3 or 4 months, and you can check levels. Some estrogen can be sprayed on. Some can be given in a gel formulation. In rare circumstances, people use injectable. It can also be given just in the vagina, which may not give you enough estrogen for systemic effects, but can help with things like sexual dysfunction. Progesterone mainly should be given by mouth or in a vaginal suppository. That will also protect the lining of the uterus. So those are kind of just some of the basics. And then the other thing I'd like to talk about is like when you are going to see your doctor and you want to talk about HRT, like when do I really encourage it? You know, when do I really discourage it? So some of the things that may be discouraging is a strong family history of breast cancer, obviously a prior personal history of breast cancer, a poor estrogen metabolism. So people who really don't metabolize their estrogen safely, we want to be more careful with that. Talking again about this 4-hydroxy pathway. Who do I think it's important that they really strongly consider getting hormone replacement therapy? Well, first of all, I think that quality of life can be very, very important and can be very negatively impacted by going through menopause, but that depends on the individual. Not everyone has problems with sleep. Not everyone has problems with hot flashes. I would say about 1 out of every 7 or 8 women seem to have no symptoms. But if you have a family history of osteoporosis, we know there's really nothing better for your bones than estrogen, then I think that's an important consideration. Osteoporosis, if you fall and break a hip in an older woman, there's a very high mortality rate associated with that. Cardiovascular disease, if there's a strong family history, I think there's no doubt, but what estrogen taken early is probably cardioprotective. We think that's why women usually are about 7 or 8 years behind men in development of heart disease. And then problems with cognition. So women that have a family history of dementia may well be carrying the ApoE4 gene. This is a very common genetic variant, present in about 26% of the population. And we believe, or we know, that estrogen is protective of the brain. So if you are at increased risk of developing dementia based on your family history, or you've done genetic testing that leads you to believe that you're increased risk for dementia, then I think you should strongly consider hormone replacement therapy, or at least those factors go into the pro instead of the con column. So those are just some of the things to think about when you're considering HRT. And it's a much more complicated subject than this. But if you'd like to do further reading, a couple of the best books I've read are Estrogen Matters, which I mentioned earlier, by Avram Blooming and Carol Tavris. And then there's a really fascinating book called This Is Your Brain on Birth Control by Sarah Hill. And Sarah has a PhD And she has been studying her whole career on evolution and how hormones have affected evolution in our brain. So this book is not so much about menopause, but it's a really insightful look into how important hormones are in our personalities, our psyche, our wants, our needs, what motivates us. So I recommend both of those books if you want to learn a little bit more about this fascinating topic. And that's about it for today. So we would love for you to submit any questions you have to ask Sid, and we'll get back to you with some answers. And we'd love to see you in Sydenham Clinic if you'd like to have a personal discussion and just talk a little bit about HRT. If you have any specific questions, then we'd love to talk to you about the topic.